So next I want to introduce Itai Danovitch. So he's the chair of our psychiatry department here at Cedars-Sinai. Just a wonderful guy to work with, and he's going to be talking about the big question, which is VR ready for prime time in psychiatry?
Thank you, Brandon. It's a pleasure to be here again, and I think it would not overuse the term mind-blowing in talking about the talks and what we've heard thus far. It is, for me, the first time I've been at any conference where the previous speakers were inspired by some embodied, sage-like presence of Freud, Steve Jobs, Freddie Mercury, and Angelina Jolie. So not sure how quite to follow that. I'm going to be addressing this question of we have all this incredible, compelling, exciting technology, all these applications. Is this ready for prime time in psychiatry? I realize I don't have the clicker. Check the podium. So, so and I would be remiss if I didn't mention that the title of this talk is really an homage to a treatise that was written by Skip Rizzo and Sebastian Koenig addressing the question, is clinical virtual reality ready for prime time? And this is a phenomenal manuscript I would encourage you all to take a look at if you're interested in this space. They take a deep dive into the assets that clinical virtual reality offers, the theoretical underpinnings, and the research on clinical utility. What I'm going to try to do is address a subset of this question, which is virtual reality, is it ready for prime time in psychiatry? And to do that, I want to put virtual reality in sort of the broader arc from a top-down type of perspective on where it fits in or where it might fit in within the broader field of psychiatry. So I'd like to begin with the beginning. In the beginning of psychiatry, at least, there was no computer, there was no smartphone, there was no headset, there were no tactile and olfactory stimuli, no haptics, there was no vibration boards. There was essentially a couch and a chair in an office. Anybody recognize this office? Yeah, no, it's not Brennan's. He has a concrete warehouse where this is embodied. It's Freud's, office. And Freud took care of patients who presented, initially at least, with neurological complaints that were found not to correspond to known neurophysiology. And Freud believed that these complaints originated from psychological problems, and that imaginal work would later be described as if work. Imaginal work in the context of this rich environment could enable people to work through problems, to achieve resolution of symptoms, to have corrective experiences. So this notion and this treatment, this intervention that Freud developed was premised on some theories that he developed. One was what was described as the topographical model. This was basically the notion that the mind is like an iceberg. And we are aware of the tip of the iceberg, the thoughts, perceptions, the rationale that we have. But beneath that iceberg, the rest of the functioning of the mind, much of it is unconscious, particularly our deep impulses, our deep emotions, and especially unacceptable impulses and emotions such as hostilities and sexual inclinations. So Freud initially thought that the goal of a therapist in this setting was to help surface the unconscious, to make the unconscious conscious, and in so doing to allow patients to work through them. But he encountered problems. The techniques that he used, dreams, associations, interpretations, weren't always effective, and even when things appeared to be resurfaced, it didn't always lead to resolution of symptoms. Patients, on the one hand, presented seeking to have their problem solved, and on the other hand, sometimes resisted the supposed solutions that were offered. And so he elaborated this theory, and he developed this model of the mind, called the structural model of the mind, in which he gave us these concepts, the terminology of the id, the seat of our primal emotions and affect and impulses, the superego, the internalized, introjected social mores and prohibitions, the shoulds and the shouldn'ts, and the ego, which is largely conscious. These other sections are unconscious. The ego that negotiates and manages conflict between the id and the superego. This was an adversarial governing system, a dynamic system that Freud reasoned must explain how people function and what the source of problem is and what a therapist should do in the imaginal setting of the office. Now, ultimately, the intervention that Freud developed and the theories would be would have a lot of problems. A lot of his ideas and his theories were based in cultural biases at the time. There were assertions that were made that subsequently been disproven. But the language that he gave, this framework for thinking about the mind, is with us to this day. And so too is the notion that there are neuroanatomical correlates to the functions that exist within the mind. So subsequently, over time, right, Freud developed this intervention called psychoanalytic-oriented psychotherapy. And there would be multiple schools of psychodynamic and psychoanalytic therapy that tried to distill what was the mechanism of change. How do you use the trappings of the office, of the therapist, of the couch, and work with the patient to help alleviate problems. And subsequent schools of therapy would elaborate on this, trying to distill what was the key mechanism of change. And then studies of these therapies tried to pit therapies against each other to ask, what is the key ingredient that helps individuals change? Is it specific factors, the focus on affect or emotions, the focus on behaviors? Is it the focus on cognitions, dysfunctional cognitions? Is it relationships? Is it groups? Is it family of origin issues? And are those the factors? Or is it common factors? Common factors had to do with the relationship, the therapeutic alliance. And that seemed to cut across all psychotherapies. The installation of hope that happens when somebody engages in treatment. The setting of an intention to change, the setting of goals and expectations. Which of these were more important? Now, and at the same time that this was all happening, there was, of course, the biomedical revolution of other interventions that came to the fore, medications and other interventions, electroconvulsive therapy and whatnot. I'm really focusing on psychotherapies because I sort of crudely categorize interventions in psychiatry as those that are external, that change us from within by immersing us in environments or by communicating with us, and those that are internal, that when we give somebody a medication or we manipulate something about the internal milieu that then changes experience. Now that's a false dichotomy. The reality is both can happen. But at the same time that all this was happening, there was, of course, a revolution of technology taking place. And psychiatry has never been an early adopter, in particular, of any technologies, but it has adopted and adapted as technologies have evolved, and we began to use computing systems to record information and to document and to analyze and eventually to communicate and perhaps even to deliver services to patients. And so where does VR fit in to all of this? And I would simplify that question into basically two formats. Is VR the contents, what happens in therapy, what's being said? Is it a tool that augments what the therapist can do with the patient? Because we've seen that it can absolutely be that. Or is VR the platform, the container? Is it the proverbial couch in the office? So to unpack that a little bit, when we talk about contents, this has been well elucidated by others, and I talked about this somewhat last year, but how does VR work in terms of augmenting an experience, in a session? Well, VR is very powerful in achieving distraction and manipulating and managing and moving attention. It can move attention in particular to cues and facilitate exposure of cues and enable desensitization, which is particularly useful in conditions that are characterized by a maladaptive response to a cue. It can be used to gamify and engage patients in repetitive activity to develop skills across a wide range of functions, simple cognitive skills, but also, as you've seen earlier today, complex skills, self-reflection, right? Intrapersonal awareness. And throughout all of this, it can facilitate measurement of these functions of performance. That's as the contents. And then as the container, VR and immersive technologies offer the ability to standardize the experience so that we can compare experiences across different people. Psychiatry is beset by variability in the way that interventions are delivered. So we can address that on the one hand, and on the other hand, it offers the promise, as you've seen, that you can individualize interventions, that you can tailor and customize an environment to be ecologically relevant to the needs of an individual. How powerful is that? Of course, it has the promise of facilitating not just intrapersonal is within the self, experiences, but interpersonal experiences between people. And then in a way that's very compelling to me, it has the ability to increase access to services, to potentially eventually reduce the cost of services, and to offer directness to psychiatric services, to democratize access to services. And that particularly is compelling to me, not just a tool that can augment what happens in the therapy, but can bring therapeutic services to people that have no access to them. As you know, as anybody knows who has tried to bring services to a friend, a family, or to a patient, there are many regions of the United States, certainly, and across the world where there's no access to mental health providers. This is a map that's colored for the density of psychiatrists, and many counties within the United States don't have access to any psychiatrists at all. And across the world, 70% of people that have an identified mental health need lack access to services. So what's the state of the evidence for virtual reality in psychiatry? This is a table that summarizes, this is actually an update of a table that I presented last year. It summarizes data from systematic reviews. So this is a type of study that collects information from other studies. It's like a meta study on conditions for which VR has been shown to be helpful. So the first three you see are conditions that are characterized by a cue exposure and the need to desensitize to that cue exposure or to develop skills to adapt to it. Phobias, post-traumatic stress disorder, and anxiety disorders at large. Social phobia, performance anxiety. There's also preliminary evidence of safety and efficacy for substance use disorders where it makes a lot of sense because, again, there's a strong feature of cue exposure and a wide range of skills that have to be learned for relapse prevention. Eating disorders where there is utility with respect to both body image and self-perception, but also managing cues around binging, purging, and psychotic disorders. You got a little bit of that earlier, so I won't belabor it. I wanted to unpack the evidence for virtual reality specifically in anxiety disorders because that is the set of the umbrella of conditions for which virtual reality is most poised to have a clinical impact that's currently relevant to our patients who suffer from anxiety disorders. So this is a figure from a meta-analysis conducted by Eric Carle and their group. And this basically applied a rigorous search methodology to evaluate all the literature that currently exists on virtual reality for anxiety disorders and identified randomized controlled trials. So 30 randomized controlled trials were identified. About half of them were in specific phobia. The other half included PTSD, social anxiety, performance anxiety, and panic disorder. And to be a randomized controlled trial, they had to compare virtual reality to another condition. And those conditions were either a control condition, a wait list or placebo control, or an active treatment, an in vivo treatment, right? A evidence-based therapy for one of those conditions. So what did they find? This is a summary. You can't read the rows here. That's okay. Those are just each of the individual studies. And what I want to call your attention to is the graph that we call a forest plot that's on your right-hand side. And this graphs effect size. And in this nomenclature, an effect size of 0.2 is small, 0.5 is medium, 0.8 is large. And the yellow bar represents 0. So everything to the right of the yellow bar represents a positive effect size. Everything to the left of it favors the control condition. And what you can see is that for anxiety disorders, virtual reality compared to placebo or to a wait list, and placebos were pamphlets, education, compared to one of those conditions, VR was definitively better. There were large effect sizes. How did VR perform in comparison to in vivo? So here you see that. These are all the studies that had compared VR to an in vivo condition. And here you can see that the effect sizes cross zero. There's a small, non-statistically significant effect favoring in vivo in these studies. So why is this important? Is VR ready for prime time? First, I would say if I'm a therapist and I am thinking about adopting VR, I'm comparing it to what I'm currently doing, right? And so I think that study comparing VR to in vivo is really important. But what has VR achieved so far? VR clearly delivers potent cue exposures in ecologically valid environments and offers the ability to tailor experiences to individual patients. VR is also distinctly engaging to patients, and the gamification of VR experiences are really powerful in engaging patients that may not engage in therapy otherwise. Studies of dropout rates in VR, which is how many people stick into the intervention, a huge problem in psychotherapy research where many people don't complete the course of psychotherapy that they're prescribed, shows that VR is similar in dropout rates. VR can definitively facilitate assessment and measurement of symptoms, which is incredibly powerful and in a standardized way. And VR, as I just showed you, significantly outperforms placebo in anxiety disorders, definitely better than nothing. And VR shows preliminary safety and efficacy in several other psychiatric conditions that we talked about briefly: eating disorders, substance use disorders, psychotic disorders. What does VR have to do to actually become prime time in psychiatry? At this point in time, for me, and I think for you, I define prime time as if I have a patient, family, or friend that I think might benefit from VR, how easy is it for me to get them into VR, right? How easily can you get somebody in? Not that easily. So what does VR have to do? It's got to continue to enhance the seamlessness of experience. Forgetting the term that was used earlier, it's the notion of the usability, the user interface, the ease of use that Diane talked about, I think is critical to that piece. It's got to continue to customize interventions to the specific needs of patients, particularly in the area where it appears to be strongest, which is around cue exposure. It has to define and figure out how to leverage the role of the clinician. If VR is happening in a therapy session with the therapist delivering it to a patient, what do we want and expect the therapist to do? How will they employ this tool, optimally? And given the fact that VR can also be a platform that doesn't even necessarily require a therapist right there, how do we develop and establish and disseminate and prove that there are service delivery models that can do this, that can disseminate the intervention and perhaps in so doing increase access or reduce costs? Finally, we have to demonstrate comparative effectiveness. How does VR, if we're treating clinical conditions for which there are available treatments, we have to show that VR offers advantages of those treatments. And in this era of concern about costs and value-based care, we have to constantly be thinking about cost effectiveness of these interventions. So I would leave you with one final notion. The theme of how to bring humanity to technology has come up several times over the conference already, and I think it's an immensely important theme. And many psychiatric disorders are characterized, among all their symptoms, by a sense of alienation, disaffection, disconnection from others. We are fundamentally socially affiliative creatures who often, not always, but often thrive in the context of relationships to others. And in the studies of historic psychotherapy work, looking at what are the agents of change, the factor that arises over and above everything else is the therapeutic alliance, the relationship to a patient achieving some kind of a corrective experience through some type of imaginal work. So how do we bring humanity to the technology? How do we ensure that instead of replacing or completing an intervention that seeks to heal and address relational problems that humans experience, how do we augment and leverage and support the development of those experiences? And how do we ensure that we can broaden and expand access to these services to all the people that might benefit from them? We'll be addressing some of this in our breakout session tomorrow, and I thank you all for your time and attention.